Welcome everyone to our Buncke Clinic Virtual Visiting Professor series. Tonight we have the distinct privilege of introducing and welcoming Dr. Jim Higgins, who is Chief of Hand Surgery and Fellowship Director at the Curtis National Hand Center. The Curtis National Hand Center, as we know, is one of the premier hand programs and hand centers in the country, and really sought out by trainees everywhere, as typically one of their very top choices. A little bit about Dr. Higgins. Obviously, we all know him. He doesn't really need an introduction, but he is the fourth chief in the history of the Curtis National Hand Center, and he did his medical school and residency at the University of Rochester, followed by a fellowship at the Curtis National Hand Center, where he has been since. He holds faculty positions at Johns Hopkins, Georgetown, and University of Pennsylvania. So clearly very highly sought after by residents from all of these amazing centers. He holds very high national leadership positions in the Hand Society, in ASRM, as well as ASPS, and he's really actively involved in all of these societies, which is pretty rare. Most surgeons typically will focus their efforts in one or the other, but Dr. Higgins, with his skill set in both microsurgery and hand surgery, is really heavily involved in all of these societies. And that's also one of the reasons why he was not only the 2010 ASRM Godino Fellow, but he was also the 2013 ASSH Bunnell Fellow. And a little bit of trivia, there are actually only 3 people who have ever done that in the history of the 2 societies, and the other 2 will be giving us talks in the next 2 weeks. So this is clearly a very, very small club that Dr. Higgins belongs to, deservedly so. He is the multiple winner. I've lost count of how many times he's won best case and best save at ASRM, but there's always a really, really interesting, challenging, complex, multi-staged reconstructions and saves that he is well known for, which especially with us at the Buncke Clinic, we every time we see it, it really warms our hearts to see these amazing cases. So it's something that I think a lot of us know him for as well. So without further ado, I'm going to introduce or give control to Dr. Higgins. Jim, again, thanks so much for being here with us. I'm going to unmute your microphone and give you presenter control. Let's see here.
Okay, I think I'm unmuted.
Yeah, and you should see the presenter control in just a minute. And I'm going to ask all the viewers to please mute your mics and turn off the webcams during the talk, and then we can turn it on out at the end for questions. Thanks again, Jim, and I'll let you take it from here.
Buck, thanks a million, and I got to tell you, it's a pleasure to do this, and it is not much of a favor. I enjoy talking about this stuff, but I particularly enjoy any sort of interaction with your center. And indeed, what was not mentioned is during those traveling fellowships, it was definitely one of the top places that I wanted to go to, and I was so happy to get to visit it. I wonder now, Babak, I'm looking at my slides, right? I'm going to presenter mode. You're seeing me in presenter mode, right?
I see you actually in regular presentation mode, and I see your mouse as well, so you can point to things.
Okay. Is this adequate? Because for me, this is full screen, but...
Yeah, this is full screen. It looks perfect.
Okay.
Yeah.
So this talk is a little bit clumsy. I'll be the first to admit it, but I think it's a conglomeration of topics that we run across when we're teaching fellows in the OR, and this is really sort of at the heart of our center is our fellowship program, and we take that very seriously, and there's often similar questions that cross the OR table, and there are a few principles that I like to harp on with them, and I've been asked to sort of congeal all those into a talk to specifically try to touch on just upper extremity issues. So it comes together in sort of a haphazard, bunch of non sequiturs all strung together, and I hope you guys will put up with that. But it does bring up interesting aspects of, in particular, treating upper extremity trauma, which I do think is considerably different than lower extremity. So, and maybe it'll lead some conversation. So, I think a lot of of a lot of micro talks about flaps or what do I do, or I really like the lateral arm, or I really like the gracilis, or I really like this or that flap. And those are interesting, but there's no particular flap that should be your mainstay as an upper extremity surgeon. We all know that, and I really hesitate a little bit to even give this talk to the Buncke Clinic because this is where these ideas were born. But I think you got to have a lot of arrows in your quiver, and you've got to play the game according to the cards that you're dealt, so to speak. So this is not just going to be a talk about, how do I fill this hole and how do I fix this bone, but more or less specific challenges in the sort of day in, day out of upper extremity trauma. So these are some topics I'll talk about. No need to even read through these, but we'll hit on them one by one. I think the thing that is particularly challenging about upper extremity, way more so than lower extremity, and I think even the lower extremity surgeons would not argue this point, but often we're in the midst of multiple stages, as Bob had referred to, and I think these are the cases that we take the most interest in and consider the most challenging and require the most thought. And I think this is what separates the microsurgeon from the upper extremity microsurgeon, because there's a lot of different tissue lines that are injured, and some of the biggest mistakes in upper extremity microsurgery are not done in like, hey, boy, how still is your hand under the microscope question, or how good are you at coapting vessels or nerves, but it's how much do you screw up the timing. And I mean, every email that I received back, and I'm sure at the Buncke Clinic, it's the same from previous fellows, they're often like, boy, I'm right in the midst of this thing. What's the next, help me organize my thoughts. And I think the timing is critical. And that's what separates sort of the upper extremity microsurgeon from just the microsurgeon who's sort of dipping their toe in the water in upper extremity reconstruction. So as we know, each of these tissue lines will require different postoperative rehabilitations. The timings of innervations are different. A lot of them will be only predicated upon success with a previous stage. So, putting the cart before the horse is really a stupid thing to do if a critical factor for that surgery is one that you have not yet performed. And then the last thing I think is, most patients just aren't going to expect a stiff hand and wrist and say, that's okay, I can walk on it. I think the stiff ankle is better tolerated, I guess this is my analogy, than stiff digits or wrists. So the functional outcome is much more demanding.
Jim, if I can interrupt you just for 1 second, would you mind clicking hide on the notice below so it hides the little GoToMeeting app?
I was wondering if you could see that, or if that was just me. Okay,
sorry. Great, thank you so much.
Sure. So then getting to these sort of questions, one of them that often comes through it, particularly if we're training fellows that in the residency program didn't have much microsurgery exposure. They might say, look, I only got a year, I gotta give me 1 or 2 flaps. I need a power flap that I can just pull that trigger every time. And some people say, well, I love muscle flaps or I love skin flaps. And I think we've all heard at the podium why one is superior to the other. And I, like everybody else, have my opinions about that as well. We do mostly in the upper extremity do skin flaps, but I think that both have great benefits. I think muscle flaps are a nice, safe, reliable thing because we know the perfusion boundaries of most muscle flaps. We don't have to guess or spy muscles. They're also really good at filling dead space, and they have a role in challenging bone healing. And that's when I will pull that out to provide soft tissue coverage, is when I think there's challenging bone healing. But the key about skin flaps for the upper extremity isn't that it looks better. And by the way, this cosmesis issue, I'll just tell the fellows over and over, like I can show you plenty of really heinous looking muscle flaps in my practice and really horrible looking skin flaps. And then I can show you some muscle flaps that look amazing and skin flaps look amazing post-op. So the like by like, I think, is some sort of like a mantra that we throw around, but it doesn't necessarily mean anything. I don't think that you're going to get a better aesthetic result when replacing skin with skin in the upper limb necessarily. So what I find, though, is the key thing is apropos to our previous statement of multiple stages is it's way, way easier to reoperate and reoperate and reoperate through skin. And you can cut it right down the middle, and you cut the pedicle in half, and you can thin it and re-thin it, and it will remain well perfused. And that's because of the issue that we've learned, from interpolated flaps, which is say groin flaps or crossed fingers, so that they will ultimately become perfused and supported by the surrounding skin to which they heal. So that permits you to go in that front door several times over the ensuing years without penalty. So that's why I think it's our go-to, our skin flaps. But again, I do think the superior bone healing issue is real, and it's important, and that's a great reason why you need to have muscle flaps in your armamentarium as well. This, of course, is a tibia, but a good example of a subperiosteally stripped tibia, where open fracture, that's risk factor number 1 for non-union. Number 2 is soft tissue stripping, and of course, beyond that is intercalated bone loss and infection. But subperiosteal stripping and soft tissue loss, significant risk factor. So when you think you're going to have a challenging osseous case and you need soft tissue, it's okay to go old school and get muscle. And there's plenty of support for that. And I love saying this to our fellows who are so hyped up on just doing skin and perforator flaps. And I say, there's a role for muscle. And that's been shown very well in a number of different studies. I'll show you a couple of these things here. Initially, and you'll hear old school attendings say, oh, it brings a lot of blood supply to the wound or to the area. And that's kind of this amorphous statement, but that's really been sort of debunked. I mean, I think you can bring blood supply with whatever axial pattern flap you have into the field. But the blood supply to the surrounding area is not enhanced any more so than with skin or fascial flaps. But I think what the real difference is this sort of cellular level difference, which is to say the stem cells available in muscle are way more apt to differentiate into, in an osteogenic manner, into bone. So we see heterotopic ossification way more often in muscle beds than in skin and fat beds. And the astroprogenitor cells from local soft tissue can help bone heal. We see that in a number of different animal and some poorly formed human studies. But let me show you a little bit more about that. So the muscle has more of a tendency to turn into bone than skin. It would make sense to have that on the surface of a challenging fracture, or long bone fracture, or tubular bone fracture for that matter. This has been shown in murine model that it will improve healing across fracture lines and speed up healing across fracture lines. And in what's only level 4 evidence, but nonetheless, in human clinical series, it has shown to improve the healing of challenging fractures of long bones. So it has a role, and I think we should consider that as an option when we think this is going to be a difficult bony healing case. So these would be the three things that I always think of before I pull the trigger and do a muscle flap. And I'm of course excluding functional muscle, which is a functional flap. I'm talking about for coverage. But it's when bone healing is challenged, when pliability over joints is not at a premium, which is particularly the wrist. At the MCP joint level, a little bit more concerned, or certainly IP joint level. And if reoperation through the bed is less likely. Now, it's not to say it's impossible. Generally, you're going to lift up the periphery of the muscle flap rather than carve right through the middle, but it does become considerably less pliable down the road. So your ability to open and close and open and close and open and close repeatedly is less likely. So here's an example. This top picture is a lady who, by everyone's estimation, had a complete resection of this septic wrist and was transferred to us after she had had an ALT flap over this dorsal defect, and the ALT flap died, and she actually came with an X-fix, and it's a long story, but ultimately after debriding the dead flap and debriding the wound and saying, all right, now we've got to sort of start to rebuild, this could easily be covered with skin, right? But we've got a long and huge jump here we've got to make in order to heal her bone. So in my eyes, this is something where it's nice. And again, the need for pliability at the wrist joint, it's not going to be present because we're heading towards fusion. So it's a good time to put muscle on. So back in the old days, we just had these double barrel fibula, or I just had a double barrel fibula available to me. I know a lot of people used scapulars or iliac crests, which I never became facile with, but these are difficult cases. You know, you're creating this sort of Wolverine construct of plates and trying to get these double barrels to touch the radius and then the four metacarpals, but not touch the thumb metacarpal and not lock up the DRUJ. It's a difficult, and get a skin paddle on the back. This is sort of a bit of a stunt. But now MFCs, I think, provide great blocks in various shapes and sizes for this particular problem. So this is what we did for this lady anyway. She had a muscle flap. She had an antibiotic impregnated spacer. She went through 6 weeks of IV antibiotics. Then we did an open culture to confirm resolution of osteomyelitis, and then she came back for this. Now, in this case, the skin paddle is for monitoring because she's already had muscle flap coverage, but she goes on to have this chunk and another Wolverine style construct here with this pliable Alps system, as it's called, to sort of touch down on the metacarpals and the radius, and the real estate in the radius gets a little bit tight, but you can do it with this little Alps system and get this thing to heal. And then I should have had a soft tissue. On the back of the hand, you have a skin paddle next to the muscle flap, but it's really the muscle flap that's doing the heavy lifting in terms of helping you get through this large osteosynthesis challenge. Pedicle and free, no need to argue that point in this crowd, but certainly free flaps give us a lot of advantages with, you know, length of pedicle, your ability to position and inset it optimally. I think those are the number one and number two advantages for trauma management. But when considering these flap harvests, one thing that's easy to overlook, and we always harp on this with our fellows when they're going through planning of how to get through these cases, you know, you might say to yourself, look, I'm going to harvest this ALT, and then I'm going to go to the leg to get sural, because that's like the number one place to get nerves. And then I'm going to go to plantaris to get tendon, because that's like the number one place to get tendon. And you just think like checkbox, and you start going through checkbox work without thinking twice about the morbidity of this on patients. And so we try to combine these donor sites. This is seemingly an obvious point, and I know a lot of you have already thought of that, but these are some of my favorites. You know, you're doing a latissimus harvest for one reason or another, and you need a length of nerve. It's not a huge length. You think about the nerve that you're going to be cutting and throwing away, which these days we know that a motor donor may have some advantages over sensory donors. So throwing away these motor donors like the obturator nerve or the thoracodorsal nerve that a muscle flap harvest is at waste, unfortunately. If you don't think of that and then later say, geez, why did I harvest the MABC, or why did I harvest the sural when I could have used these other donor nerves? TFL from the ALT, that's a pretty obvious one. This last one here is my favorite, which is taking a gracilis flap for whatever reason, function or otherwise, or coverage, and then taking this split thickness skin graft with a machine off the side of the thigh is like, that is so avoidable. And the patients hate the skin graft donor site more than anything. You know, you fuse their wrist, you know, they end up being numb for whatever other reason, and their finger has been reperfused, and all these donor sites for vein grafts, they'll complain about the skin graft donor site. So what we typically do at this point is on the medial thigh, we just run a dermatome down the medial thigh, and then we make an ellipse and draw the ellipse around the dermatome scar. And then we cut out the rest of the skin as a split thickness graft with a knife, put that in the back table, throw away the skin, or the deep dermis and the fat, and now we've got massive access to the gracilis. Gracilis comes out in a hurry, and you sort of slam the whole thing closed with a straight line incision. So end of the day, patient's got, you know, gracilis muscle skin graft and seemingly no skin graft donor site. So it's not ingenious, right? But it's right in front of your face. So it's things like that I think are important to consider. And then this last concept of local flaps being low morbidity, I think this has just got to go away. You know, in particular, the use of the radial artery, and here I am talking about the use of the radial artery, and a place where there's a ton of radial forearm flaps being harvested. But keep in mind, I'm talking about for upper extremity coverage. There's a place and a time for radial forearm flap harvest, particularly because it has so little hair on it and it's so thin. So there are great times to harvest this when there's no other acceptable donor site. But when you're working on the hand and you're trying to cover the hand, I think the day of the radial forearm flap, reverse radial forearm flap, has come and has gone. And I think there's so many other options that we have available to us that I don't think this should be in our quiver as hand surgeons. And you might say, why? It's been, it's tried and true. It's as old as the hills. Everyone does that. It's not a problem. I've done a billion of them. And look, there's so many papers proving that harvested radial artery is okay. And that's true. There are a lot of papers, particularly from cardiac surgeons who harvest them for cabbages who see patients once or twice post-op. But there's a lot of data, which is interesting data, demonstrating the acceleration of atherosclerosis of the ulnar artery. And let me show you, it's a little plug for my own paper. That's a class move. Okay, here's a little discussion of why the radial artery is actually more important than we might think. So for starters, I would say that most people, if asked, most trainees, if asked, hey, what is the dominant vessel to the hand? You would probably say, well, it's the ulnar artery, because I see the ulnar artery. It goes right into the superficial palmar arch. I mean, it plows right into that thing. It's got to be the dominant artery. And that for a long time was thought to be the truth, primarily because it's been observed to be the primary inflow for the superficial palmar arch. However, as it turns out, there's multiple arches in the hand, as we all know now, and its visibility on superficial dissection doesn't make it the dominant artery. And so here's a paper from 1989. This is not new data. This is from Louisville. Healthy volunteers being ultrasounded, and they found that the radial artery was dominant by pulse volume recordings, doing balance tests in these digits, this percentage of the time, which is to say, what does that mean? That means that when you compress the radial artery and you compress the ulnar artery, which one dampens the waveform more? And in even the small and ring finger, where we always think, the ulnar-sided digits are going to be primarily supplied by the ulnar artery, as it turns out, the radial artery was more commonly the dominant artery for all 5 fingers. Interesting paper. And then again, shown in our center in 98, also not new data, but this study was one where a bunch of patients, our hospital was huge for harvesting radial arteries for cabbages by our cardiac surgeons. And so they had all these patients who were being tested pre-op. And we took all those tests to try to determine the dominance of this population, radial or ulnar. Now, this is a funny looking graph, but if you look at it, the black columns are the percentage, right, 10, 20, 30, of dampening, or I'm sorry, the percentage of patients that had this amount of dampening. And let me rephrase that here. So when this is the PVR ratio here on the x-axis, if there's a 1.0, that means there was no dampening. If it was a 0.8, it would mean there's 20% dampening, 0.6, 40% dampening. So really the critical dampening, the 90% dampening of the waveform occurs in this far left column. So really our eyes should be drawn to the far left column. And this shows in what percentage of the patients did they show 90% or greater dampening with radial artery compression. And as it turns out here for the thumb, it was 25%. For the ulnar artery compression was 2%. Likewise, radial artery 25%, index finger 3%, ulnar artery. And in the 5th finger, where you would think the ulnar artery would be of critical importance, if anywhere, it was again greater than 20% were radial artery. The loss of the radial artery was of critical dampening, and only 5% was loss of the ulnar artery, demonstrating critical dampening. So it's to say that if you're to harvest the radial artery, you have a much greater chance of creating a 90% or greater waveform dampening in all 3 of these fingers, 5th, index, and thumb, in patients. So more often than the ulnar artery, the radial artery is the dominant vessel. So I clumsily explained that, but interesting paper indeed demonstrating the radial artery is the dominant blood supply to the hand. And our last study that I would just cite is in this fascinating study where they took patients that had radial arteries harvested for cabbage, and they found out in this first study, how does the blood supply to the hand change after you remove the radial artery? And as it turns out, initially, the flow, if the flow is measured in cc's per minute, would decrease. And that decrease would then ultimately returns to normal. And the way it returns to normal is by an increase in velocity in the other two arteries, the interosseous and the ulnar. And actually, most of it's born in the interosseous system, which is interesting. So you will compensate for sure. However, they then took patients who had had an artery harvested 10 years ago on one side, and they compared the ulnar artery on the side where the radial artery was harvested to the ulnar artery on the side where the radial artery was not harvested in the same patient. So it's almost like you have an internal control. And they found that there was increased intimal medial thickening as measured ultrasonographically, and increased plaque formation. So these patients were not in crisis for sure, but it was a very elegant way of demonstrating an increase in atherosclerotic change by the changes that are created by velocity changes across those vessels over time. So that does result in, you see these case reports, hey, this person had this harvested, and years later we went into critical ischemia. And you run across cases like that, like this patient who had a radial artery harvested 2 years ago, was doing fine as far as the cardiac surgeon was concerned, but then comes in, he has this racing stripe on his arm from previous harvest, and now he's critically ischemic. And so you would see the surgical absence of the radial artery, and then this corkscrew finding here in the ulnar artery consistent with ulnar artery thrombosis, which ultimately put him into crisis. So it's an entity and it's real. And you might say, well, it's rare, and I agree. However, it's certainly avoidable. And the ways to avoid it these days are, if you love the radial artery, you can take perforators off the radial artery, particularly this distal cluster, which is really the one that's commonly used. This one is very uncommonly used. This only does supply you, however, with smaller amounts of tissue in my experience. The true extent of the angiosome of this is somewhat unknown, and it is a perforator that needs to be rotated, so there's some limitations there. But on top of that, we have a whole, army of free flaps that we can perform, and I think as hand surgeons, we need to be capable microsurgeons these days. So I think there would be no time in a lower extremity where you would say, I think I'm going to harvest this flap based on this critical vessel to the lower limb. The only time we do that is with the perineal artery, and certainly this is for in extenuating circumstances where for a long time the fibula was considered really the workhorse, the only commonly used vascularized bone flap. So we've got a lot of options, and that's my plug for preserving the radial artery. Shifting gears a little bit to the issue of emergency coverage, a lot of fellows ask about free flaps in the emergent setting, which is to say, night of injury. And this does harken back to the work of Marco Godina, and everyone always quotes Marco Godina about his emergency free flap concept and how that at the time it felt as if that was going to be a current that was going to carry through microsurgical reconstruction. However, I think the vax changed everything, and people use that for temporizing wounds during this hospital stay so that you can come back and do your free flap a day or two or three or four or whatever a week later. What I like most about it, frankly, is its ability to enable you to do a sterile washout in the OR and then have a sterile dressing on that wound that remains sterile until your next OR serial debridement, among other advantages such as loss of domain and such. But so I think the VAC has changed emergency free flaps. However, I do think there's a couple of special considerations and times when I get a little bit concerned and I start thinking maybe we should just haul off and do a free flap right here and right now. And that's concern about revascularization at the time of free flap and the difficulty of subsequent free flap if you have a long vein graft in there. And then the second is subsequent tourniquet insufflation. And there are times when we get away with both of these issues, but this, if there was a time when this issue comes up in my mind, it's this particular scenario. So here's a guy, roll over, he's got a big wound, right? And his hand is ischemic. If you look at it, he's sort of taken a 9-iron right out of the fuse box here in the antecubital fossa, so a lot of nerves are out and vessels are out, and his hand's not perfused, and he's going to need coverage. It's, you know, that's the distal humerus there, sort of shaven down. So in this situation, you can put in a long vein graft for sure, but your question is, are you going to send that patient to the floor with a vein graft in Integra, or a vein graft in Xeroform, and a vein graft or whatever? And some people get very nervous about that. Some people would like to have it covered. My biggest concern with these cases is if I do send them to the floor with a piece of Xeroform or Integra or whatever else, and I think I want to come back and cover it within the same hospital stay, I don't like to insufflate a tourniquet upstream on this and cease flow across this long vein graft for any duration of time. Could do the case without tourniquet for sure. But I find this to be the sort of go-to maneuver that works best for me. And that's just getting one of these branched vein grafts, reperfusing the limb that you're working on, and then dropping those clamps, and now you can just put a clamp across here and do your end-to-end into the branched vein graft. Now, it does require that this branch go in the right direction, obviously. And that's actually a little bit of tricky business. So if you can imagine as a vein graft, that means that this was distal in the leg, and this was proximal in the leg. So that means, and we want this outflow to be efferent. So that means that in the leg, this vein was distal, and these two branches were heading proximally. That's a less common pattern than you finding two branches coming from distally, entering a single vein and heading proximally. So you sort of have to look for that slightly unusual bifurcate proximally returning vein for this to work. The other alternative here is, of course, a flow-through flap, and I don't think a year has passed without a fellow or resident saying to me, "Can't we do a flow-through flap?" And I can't stand flow-through flaps, and I don't know. I think the main issue about it is I think there's this attraction to the sexy, and that's natural, and you want to do something that sounds really interesting and cool. But the two biggest detriments in my practice for flow-through flaps is that by definition, the flap, it sort of limits how you can orient the flap, because the pedicle of the flap may have some freedom from the flap, but not endless freedom from the flap. And so it removes from you one of those great tools that free flap surgery provides you, which is sort of freedom of inset. That's number one. Number two is, more often than not, skin flap, and this would get a skin flap, more often than not, skin flaps will need debulking in the upper limb. And when you debulk, I like to be able to debulk, aggressively, particularly something like this is in the anticube. No one tolerates a big fat wad of skin in their anticube. They want this thing thinned down later so that they can recreate the crease in their anticube. So when you're debulking like that, I sometimes like to debulk twice or three times even, and you want to be able to go as aggressively on this thing, and as I said, even cut the pedicle. And the last thing I want to do is have the pedicle be the perfusion to the limb. So for those two reasons, I really shy away from flow-through flaps, but it's a possibility. This in summary is, and it's not that fancy, but it's the way I find it best to sort of release clamps, take a breather, and just start doing your free flap. As it's sort of shown here, right? So you get this, and it's pretty obvious. I mean, now all you got to do is go get veins for venous return, and you're doing a bunch of end-to-ends, and the case is over. Here's this ALT, which I think is pretty big, but it looks like a small hors d'oeuvre on a huge cracker here because of the size of this wound. Of course, the rest is skin grafted. So that'll be the time I think about emergency free flaps. I think other people have a lower threshold for doing that, but that's when I start wondering about it. Other topics, shifting gears, when chatting with the fellows about cases when we're doing elective free flaps for upper limb. You know, once you're doing these sort of elective things, these are, now you're getting into sort of the fancy stuff. And fancy sort of falls into 3 categories in my mind. It's usually, you know, free bone, functioning muscle, or toes. And those, all 3 of those, I always say you're going to need more skin than you think. You're going to need more skin. And any sort of veteran microsurgeon, well, that's obvious. But when you're a fellow, this is, for some reason, it's not obvious, right? Because you're starting with a soft tissue envelope that's closed. You're going to say, oh, everything's in there. I'm just going to take out A. I'm going to put B in. We're going to call it even, and there won't be a problem. But bone in particular, this is an easy one to get caught with. Here's a great case of a delayed reconstruction. This kid had a closed skin envelope and a long ulnar defect. This is antibiotic impregnated cement spacer. So we swapped it out for this fibula, right? And you'd call that a 1-for-1 deal. But I'll tell you, we were pretty happy we had this, by anyone's estimation, sizable skin paddle along with that fibula. And it closed very nicely. We weren't sort of horsing it down on top of our anastomosis. And we got the ability to monitor. So fellows often ask, hey, do you think I'm going to need a skin flap for this fibula? And I say, I almost can't remember when I've not used a skin flap for a fibula. It would be rare. Here's an MFC for phalanx. I mean, the farther and farther you get out in the limb, you know, the narrower these cylinders of skin get. So the forearm is challenging, the hand is more challenging, the digits even most challenging. I was going to say in the slide earlier, maybe the one time a fibula would be relatively straightforward without skin might be in the brachium, right? So you're in the upper arm, particularly in a floppy armed person, like a patient's got a lot of extra tissue up there. You might be able to get in and get out and close up and not feel too bad about it, but you wouldn't have any monitoring, of course, unless you buried a implantable Doppler. So anyway, my point is just get ready for skin. Any long bone or tubular bone reconstruction, they're getting skin. Here's an ulnar defect, osteomyelitis, MFC. These x-rays are interesting, and it does heal really quickly. But anyway, here's what he looks like in his tie-dye. And there's the skin paddle. You know, and you can always, if they don't like it, and they usually don't, you can just go back later when that bone is healed and say, hey, just come to my surgery center. We're going to just try to chop that thing right off, and boom, it's closed. No problem. You don't need to worry about the pedicle. You just swipe it off. Other considerations, oftentimes there's this confusion amongst our fellows about, hey, if there's something over here, shouldn't we be coming in from the ulnar side? And I always dissuade them from that because it's almost like the snuff box was sort of made for us, you know? I mean, it's the radial artery is taking this foray through the dorsal hand for just a couple of centimeters, as if it's just sort of saying, look, if you need me back here, I'm ready to work. And that we always come in from the radial, whether it's a radial sided flap, a central flap, or an ulnar flap, like always come in from the radial side and through the dorsal, less innervated skin. Anything that requires sort of pounding around through or pounding through glabrous skin in the palm is a big no-no. So we always go in from the radial side. It's just easiest. And also the FCU is kind of, it's kind of in an inhospitable location underneath the FCU here. It's just not very easy for passage of vessels and setting up your micro, and it leaves a big wad underneath their ulnar wrist, and that's sort of where they lay it down on the table. So always coming in from the radial side. Holds true for the first web too, which is something that we always obsess about in hand trauma, because you can see somebody, as I'm sure Rudy Essie was on here and Babak will say right away, you know, I'm looking at a crushed up hand in the ER, you can just sort of look at it and say, what may make or break this guy's function in the end of the day is his first web space. And if that's not wide enough, we're going to be struggling and struggling and struggling. You can do all you want, but so oftentimes when you see a defect like this, and there might be a fracture of the metacarpal like his was, this patient came to us with some, I think it's just pig skin or allograft skin and some K-wires. And we took this off and sort of plated them up, and then we were going to cover it. And you know this is going to be tight later, so just sort of bank stuff in there. We actually cut through that first web, which seems counterintuitive, right? You're always told don't cut through the first web. You know, you want to make it contracted, but it's okay if you're jamming extra tissue in there. I say go for it. You just send a tongue in there, give yourself a little extra room for later, because this CMC is going to be stiff and you're going to want to be working that thing out. So always think about the first web. The skin interruption I talked about, we always go in from dorsally, even if you're trying to do first web space releases. Sometimes this is a confusing issue for some of our fellows. So here's a patient who, this lady was just absolutely incredible, septic shock, multiple debridements, lower extremity amputations, needs her upper limbs for ambulation assist. Her spirit was just incredible. So the woman just could not be knocked down. But so anyway, you got to go in here, right? And it's tempting to say, depending upon your defect, now here it screams out, look, resurface this. But sometimes you'll have a bunch of scar and stuff in here, and the fellows might say, oh, I'm just going to come right, look, the radial artery is right here. I'm going to waltz right up through here. And if you do that, then that means you've got to remember the tarmac between your anastomosis and your flap, unless you're tunneling it, and this is pretty inhospitable for tunneling. Unless you're tunneling it, that means you got to cut through what in this case is super valuable glabrous, adherent, septated palmar sensate skin. Over here, it's nothing. You just cut through this stuff. It's radial dermatome. Even if it was normal skin, you go through there, you can plow in and dump it into this first web space. So these first web releases, you're always coming around the back. Even if it's clumsy and you feel like, geez, I'm looping around the hand, always come in for the back. So that's what this person got with the lateral arm. So skin for debulking and opponent's plasty. There's the opponent's plasty. But anyway, you see it sort of awkwardly comes around the back, and then you nose dive into that first web space. And she's way better off than had we headed straight up the front here and interrupted her palmar skin. And these can be debulked and redebulked. And looks like she probably needs a debulking. So here's another one, big crush, contracture. This one, this is super tight. And that's tempting. You're like, look at that thing. It's on the palm side. I'm coming right in the front door, but I would not do that. You got to go around the back, and not resurface it from the back. So coming in from here and you're preserving the skin. Definitely the way to go. This person, I think, had maybe an adductoplasty also. Anyway, they can be debulked readily, no problem. Speaking of free flaps and speaking of the radial artery, and speaking of how easy it is to go into the dorsal hand, because of its ease of accessibility throughout the forearm under the brachioradialis, it's often the site for multiple inflow opportunities and staged reconstruction. So this distal third, like you just saw there with the lateral arm flaps, is used for skin often, first web coverage, maybe coverage of a thumb stump, going into the snuff box for toes and the like, or coverage of distal finger injuries. And then of course proximally for, maybe free bone, maybe functioning muscle. So this radial artery, you can go in and decide again and again and again. And don't say to yourself, geez, we already tapped into this thing once. There's going to be a flow disturbance. I better not touch it again. That is not true. And I'll show you. We did a study about end-to-side anastomosis because, we all say, hey, I do end-to-ends, I do end-to-sides. I like this technique better. And the end-to-side folks always say, well, I like to keep the vessel open. But, that's not really been shown. So I wanted to sort of study that and study it in sort of a robust way. So you might say, well, end-to-side anastomosis is more dangerous. It's more dangerous. Don't do end-to-side because it's going to have abnormal flow and it'll collapse more. But we know for sure by multiple studies that end-to-side and end-to-end have equal patency rates. Most recently, this JRM article 2017 showed that nicely. So you might say that, well, if we did an end-to-side anastomosis, maybe the downstream artery wouldn't remain open. And why would you think that? Because there's been some, albeit now pretty old, papers in the 90s saying that if you did non-critical vessel repairs, like the ulnar artery or radial artery repair at the wrist in a spaghetti wrist, that it would not stay open 18 months later because there's collateral flow. So if you're disturbing the collateral flow and you've got a patent other vessel, maybe it wouldn't stay open. So what we did to sort of study this is we took all these free flaps and we figured out which ones of these did we do end to side and which ones of these or non-critical vessels. And that means either the posterior tib, anterior tib, radial, or ulnar. In other words, not when you're working in the thigh or in the brachial artery where it's a quote critical vessel. So just taking these distal limb free flaps, their success rate was as would be expected, and then tried to study them. Now what we wanted to do is study something ultrasonographically where we could get distal to the anastomosis. So anything that was right at the wrist crease, out. Anything that's in snuff box, out. And actually that eliminates a lot. But if you've got sort of a mid-shaft forearm or junction distal third, middle third anastomosis, you can easily ultrasonographically visualize the distal radial artery to where your end-side anastomosis is. And then, of course, you can have attrition from people not being willing to be enrolled or not following up. So bottom line, here we end up having this study of 15 patients. And we do a bunch of duplex ultrasounds on them, pulse volume recordings, and try to study the flow dynamics. And it's pretty interesting because ultimately you want to see not only is it patent, but is the flow, quote, normal downstream. So we had one years and years later. Now, these are all viable flaps, but this is years and years later. This is now thrombosed. So interestingly, we did a 1 in 15 thrombosis rate years later. But these are the resistive indices. So think of this as relative to the brachial artery of those vessels downstream. And here's a sort of comparison of the vessel that we did the anastomosis on and what we call the ipsilateral collateral vessel. So if this was the radial artery getting an end-side anastomosis, this was the ulnar artery in the same limb. So no difference between these two. And then we've visualized the flow downstream with color Doppler flow monitoring. But here's the cool part. And we wanted to see, does the rheology change? So it's a funny word, right? We're trying to see, like, how is the flow characteristics in the blood vessel distal to the anastomosis? And so we checked two things: volumetric flow, meaning is the volume of the flow distal to the anastomosis same as this, a radial artery in the opposite limb? And how is the turbulence? So if you get into this and you start digging into it, there's something called a Reynolds number. And this is shown here in this equation, but keep in mind this would be the peak velocity of the fluid going through it, the diameter of the vessel, and this V is a standard for the fluid that you're using. So we used a blood viscosity number for temperature of human blood. So that's 2.65. So whatever that might be, you pump it into this thing and you can conclude what this Reynolds number is. And to say laminar or normal flow would be less than 2300 and turbulent flow would be greater than 2600. And then you might have this sort of transitional stuff. It's a little bit turbulent in the middle. It's a way of quantifying how much turbulence you have. And what we did is we looked at the anastomotic vessel downstream and the collateral vessel on the same limb for volumetric flow, meaning is the radial artery seeing a lot less flow because the ulnar artery is stepping up because you did this endoside that was so damaging to it? And the answer is no. And here's a Reynolds number if you compare the anastomotic, let's say it was a radial artery downstream, and the contralateral same side vessel. So if it was a radial artery downstream from anastomosis and radial artery on the opposite limb, no detectable difference. And in fact, if you looked at these, the flow in both of these things, just to put it into sort of perspective, transitional flow would start up here and then turbulent flow would be up here. So this is well within the laminar flow region. Only to say it's an interesting and sort of scientific way of really demonstrating that end-side anastomosis is not only a good idea, it does maintain patency downstream, and it maintains normal rheology and vessel flow downstream, which is a cool, I think, a cool concept that should be hopefully in print pretty soon. So anyway, endoside, it's worth it, and can be done over and over and over again. Here's a banked thumb onto the radial artery done end to side, right? So this guy's super duper mangled, needs a bunch of washouts, needs soft tissue coverage in the first web. We bank this thumb. That's interesting, but I don't want to just blow over that. But my point here is that this fellow had an endoside anastomosis here, and then about 9 days later, we did an upstream and end-side anastomosis for this lateral arm flap, and then took off this thing and replanted it in its appropriate position, the distal thumb, again in the radial artery downstream. So all of these things brought another anastomosis into the radial artery. So it just goes to show you, don't fear going into the same vessel time and time again for the purposes of reconstruction. Indeed, you can do it at the same time. Frequently, you'll find ourselves doing in-series anastomosis and other banking case. So you can go boom, boom, right side to side in the same. In fact, this is an easy thing to do. Believe it or not, you just put the clamp on there and go back wall, front wall, boom. The whole thing goes down and you're good to go. So don't fear multiple taps into the side of the vessel. 8:52. I'm gonna try and close in this next maybe topic, and I apologize. We talk about this all night, but maybe just one more topic, and this is this issue of dorsal hand coverage with syndactylization. So injuries out to the tips of the fingers or somewhere along the fingers. This is always an interesting situation. So this fella came to me because he was in a convertible on his way to the Super Bowl in Florida or whatever, New Orleans or something one year. And he flips his car over and he's there on the side of the road, car's upside down, he's unconscious. Who do you think comes to his rescue? That's right, Kevin Costner. Kevin Costner pulls this guy out of the car, and then they put Integra on his hand, and then he comes back to Baltimore and we cover him. So the message here is that although a lot of your attendings take care of like professional athletes or take care of famous people, I take care of people that get in car wrecks and were pulled out by famous people. That's like the extent of my exposure to famous people. two steps removed. Anyway, so this guy, it's an interesting story, admit it. So this guy, big wound, extends onto 2 fingers. And in this case, you might say, I got to create these tongues of this flap or that flap. And I always say, just take the skin and syndactylize them. And you shouldn't fear syndactylizing them. It's just like a groin flap where the, underneath here is exposed. In this space would be exposed fat right on the flap. But keep in mind, you might say, geez, you're creating syndactyly. That's like a problem we struggle with in hand surgery. I mean, there's a whole field of congenital surgery that focuses and it goes on and on about syndactyly releases. But keep in mind, the challenge of a pediatric or congenital syndactyly release is recreating this thing right here, which I'm just going to call the frenulum. That's like, when I say web, it's hard to say. What do I mean by web? Do I mean like everything from the dorsum to the palmar aspect? Really, the thing that's challenging, right, that people always focus their flaps on, and how do you make your flap, and where do you sew it, and do you cut the natatory ligament? It's always trying to recreate that. These people have that. When they skin the back of their hand from burns or rollovers or big trauma, they have it. All this stuff's in there. So you just cover it, and then the next time you come back, I mean, if you want to, you can even not use any anesthesia. You just take a scissors and go whoop, right down the middle of this thing, because he's got his frenulum. So easy case. They can even move postoperatively if you'd like to. Extensor tendon reconstruction comment here. Whenever these tendons are stripped, I always say, look, we usually don't repair these extensors or don't graft them. But the key question are the sagittal bands. If you've got good sagittal bands that this won't subluxate radially or ulnarly, then it's worth reconstructing them. If there's no sagittal bands and you're just stripped all the way down to joint, don't try and run this guy all the way out to the central slip or try to run it out to mid-shaft of P1. It's going to ultimately subluxate and be very unlikely to succeed. So that's sort of our algorithm for extensor tendon reconstruction. 8:55. I'm gonna throw one more in, Babak, but this is the volar hand. So oftentimes you have this big volar defects, and I always tell them, our fellows, let it granulate. Let it granulate. Don't look. It's sensate glabrous skin. It's too important. Don't put a big wad of skin on there. It's kind of like when I was in residency, I used to always be told by our and this probably isn't even true anymore, but I remember Joe Streletti and everyone always say, look, the medial canthus, this is an area that'll heal by secondary intention. It's kind of like Mesopotamia. It's just, it's such fertile ground. You don't have to do anything. I would say the same for the palmar skin. Don't put a flap in there. Let it heal by secondary intention. Use scar releases later, but covering it with skin graft or something that is skin-like is not a good idea. When you have to, though, always consider the debulking to sort of recreate, and this is going to be my closer, I promise, recreate the physical appearance of a hand. So this kid's a poor kid who got run over by a lawnmower. We did an ALT flap here because his median nerve was exposed. And now he went and got in a toe. As you can see here, his parents didn't want to give up his great toe, so we have this unfortunate second toe. But my point is, one of the things that looking at this kid's hand that's going to make you, if it was dark or if you squinted, say that's not hand-like, isn't actually the cascade of his digits. This part's pretty acceptable. This cobra-like posture of the second toe certainly is offensive, but what I would say is it's the loss of a wrist crease. So if this was a silhouette of a hand in the dark, you would say that's not really hand-like because you're missing the wrist crease. And our eyes want to see, they want to see a thinner eminence. You just want that. That's a hand. That's a human hand. So when we debulk these, we could go circumferentially around the margin to preserve the scar or not create a new scar. Or you could use the access to your advantage in two ways: creating scars where you want lines to be seen, and number two, creating dog ears. So we spend a lot of time avoiding dog ears in plastic surgery, but the way you create a dog ear, right, is you create one limb length to be uneven with the other limb length. So if you attacked this in this fashion and said, I'm going to force this short limb length to get over here, that means you're going to crimp all this thing up, right? You're creating this sort of reverse dog ear scenario. So if you create this, it'll crimp it up and you'll create this topographical three-dimensional situation here. Again, pulling the short ear up or short limb up to this long limb, crimping this up, and ultimately recreating sort of a more hand-like structure. Now, part of this thing, now, if you closed your eyes, everyone to squint, if you looked at it, you'd say, well, it's more hand-like. Part of it's because that bank exists. Notice that? That's making it hand-like. But also, I would argue, the three-dimensional topographical line here is definitely making your eye think that's hand-like. And it also helps if you put purple magic marker along these spaces. But at any rate, this we published in a visual subunits of the hand paper, which I think it's an important thing to think about, right? And you might just say, look, I'm going to mail it in. I'm just going to debulk this thing. But it's times like this, I think, where you got to say to yourself, this is where plastic surgery, the aesthetic meets the reconstructive. And it's a good time to just take an extra minute and figure out how we can use our surgical tricks to, make this kid a little bit happier. Anyway, I'm gonna stop there. Here's where I failed. I should have made that a little tighter. See if that was a little bit more distal, that crease would look a lot more thinner-like. Babak, I'm gonna pull up here because I know it is 8:59. So let's can I field questions maybe? I'm sorry I took so long.
Oh yeah, no. I think we're going to open it up for sure. I'm getting a little bit of reverb here, but I think hopefully people can hear me. First of all, awesome talk, amazing. And I think if my webcam was on, you would see me nodding pretty much throughout the whole talk, because a lot of the points that you were making were definitely things that we are in complete agreement with you on. Doing very similar type cases, I think that you certainly hit the nail on the head with many of the points that you've mentioned. And I want to just kind of comment on a few things, and we'll open up for some questions, kind of in chronological order of your points that you were making. Let me actually go to let's see here so that we can get rid of. Yeah, good, perfect. So with regards to muscle flaps, I think we fully agree with you. We still love muscle flaps, and even though we do a lot of skin flaps, muscles are still something we do a lot of, and they can look quite good. It's just the indication of when you use them. And I think, to your point, I think a lot of people have stopped doing them, and they've stopped becoming comfortable with actually doing a really nicely done muscle flap. So I think I definitely agree with you there, and we as a group do as well. The concept of local flaps being less morbid, absolutely. I think it's definitely not a true statement. And oftentimes local flaps end up not being enough. So you then have to go back and do another flap on top of that and whatever. So definitely a good point. The entire segment that we talk about the radial artery is so interesting, and I think, and especially the part with the endoside anastomoses. I think first with the radial forearm flap, I totally agree with you. Before we started doing phalloplasties, which unfortunately there's no other flap that can do that in the body. We rarely ever harvested a radial forearm flap, and even if we did, it would be such a small one that we could do it off the perforator, or maybe even reconstruct it with a little graft or something. I haven't done a reverse radial forearm since early on in my residency, and it's kind of the same reason, because I think you're sacrificing a major artery, and also you're getting rid of a potential recipient vessel for your future use. And so we are also in complete agreement with you about the reverse radial forearm flap not really being, in my mind, in today's world, kind of a workhorse flap as it may have been in the past.
Totally.
The endoside study that you showed, fascinating. I'm looking forward to seeing that paper come out. It makes intuitive sense. Obviously, it's nice to have data behind it, because we do love endoside anastomoses. We do it all the time. Our fellows can attest to that. It's not only a good skill set to have, but I think it's nice now that you've done all the work on that to show that also from the flow standpoint, the flow characteristics are also better, which is really nice to see. With regards to the flow through flaps, also agree. I think, I know Rudy Bunke, when I was a fellow, would tell me, never ask a flap to do too many things. And I think it's true, because you reduce your degrees of rotation or degrees of freedom that you have. Oftentimes the distal artery may not be as big as you think it is, unless it's a forearm, which is a weird kind of thing. But I think you're right in that we usually try to have one flap do one thing and then reconstruct it with something else, be it a vein graft or an arterial graft or something like that. The cases that you show that are these multi-stage reconstructions where there's a toe and there's a flap, I think people in the audience, I'm hoping they realize the complexity of these cases, and the fact that you're just showing this beautiful end result. It's really after very careful planning and carrying out these stages in the proper way. And I think it's hard to emphasize that enough. And I think I just want to mention that these are beautiful cases that are actually a lot harder than they seem. And the thing about you need more skin than you think, it's so true. In fact, I actually have a slide on that, is that you always need more soft tissue than you think. And our nemesis is the first web space. It always is. It always is. And so we tend to almost overcorrect just to bring in more tissue, because in the future we know we need it. And if I had a nickel for every time somebody would come in from the outside with a contracted first web space, that wasn't treated originally, I think I'd be a very rich man. And then the one more comment before we go to the questions, the radial versus ulnar side of the hand. It's such a good point about the radial artery, especially in the snuff box. It's just made to be a recipient site. But what I would add to that as well is, and also I learned this from also Greg Buncke and Rudy Bunke when I was a fellow, is that the venous system on the radial side of the hand is also so much better and less prone to being compressed, because with the hand being positioned the way it is, it's going to be resting in a splint on a pillow or whatever, and you're always more prone to compressing your ulnar side of the hand a lot more. So that's that's another yet another reason that I think the radial side of the hand is better. Sorry, go ahead. I don't know if you had a comment on that or not, but
well, it actually speaks to things that are interesting. This talk, and I like, again, I hesitate giving it to your clinic because it's so obvious to you guys. But I think anyone, whatever stage you're in your career right now, like, you could either listen to this talk, or you could just find out all these things anyway, because sooner or later it's going to become apparent that these things are problems, and it's only by taking a lot of hits that you come up with these. But it is the kind of thing where experienced surgeons will be nodding their head and say, yeah, that's true. So I think all those thoughts are just sort of tough lessons learned, and it's just easier to shortcut it if you can synopsize those for fellows. Trying to read some of these questions in the chat room here. Can anyone else hear me? It seems like we just lost Babak.
Yeah, we can hear you.
Okay, good. I
Yeah.
wasn't sure if I just got lost or if Babak just got lost. So he's probably on his way back in. I was trying to read some of these questions. I'm going to just read it off so I can think. This is a question from Kyle. It says, one of the biggest challenges I have had is whether to skin graft versus flap proximal forearm muscle belly when you can't close the skin, like for example, after fasciotomy for trauma. I always regret skin grafting when I can't cut it out in the future. In other words, what are your thoughts? In other words, you've skin graft, and I see Kyle, you're still on here. You skin graft the proximal forearm, and then the patient maybe doesn't like the scar, or you say, geez, now the soft tissue envelope is so thick, I'm going to bring it back to native skin to native skin. And that's hard to do because you're peeling it off muscle. Does that sound about right, Cal? You'll have to unmute yourself. Baba, can you hear me or no?
I think we might have lost Babak, but we can still hear you.
So I guess I would say to that, I haven't had trouble excising those skin grafts. It can be a little hair raising if they're sitting on top of nerves and things like that. But the thing to do is I typically will excise it from one side and move radially or ulnarly accordingly, and just reconfirm that I've got enough pliability of my adjacent skin, and then continue to cut out as I go. But I would, there's Kyle's back. I would cut the skin and elevate it off the muscle, and it sometimes is a bloody operation, but just avoiding, of course, if there's nerve directly on it, you may hesitate and say, forget it, it's not worth doing this. I may irritate your median nerve. Baba, you're back now.
Yeah, sorry about that. I lost internet for a second and it hopped back on. So sorry
Yeah,
about that.
I wasn't sure for a minute if I had floated away or you'd floated away. I thought I was like in a room alone. I was just trying to knock off some of those questions in the chat room.
Yeah, did you get to the endoside vein repairs? Did you get to that one?
Yeah, I saw this question. This is Gopi, and it says, thanks for the presentation. Any tips for venous anastomosis and serial multiple endosides? That's what you're referring to, right, Babak?
Yeah, yep, that one.
Yeah, so I think this is totally what Babak says is the case. If you're on the radial side of the hand, this is not usually a problem. It depends on how tattered your surrounding soft tissue was. If you're in a field of skin graft, that's going to be difficult. The radial veins are much more user-friendly than the ulnar veins, and the superficial veins on the radial forearm are much more multiple and user-friendly than ulnar veins for sure. But if I knew that because let's say the arm was circumferentially skin grafted or the like, that I was just stuck with deep veins, boy, I'd certainly be happy to get 2 deep end-to-end vein anastomosis to my radial artery system and call that a day. I'd be happy with that. I usually do 2 veins for every artery. If you're doing, as you say, multiple endosides simultaneously, they're usually remote from one another. And I did show you a banking case with 2 fingers sitting right next to one another. I don't want to pretend that that's like a de rigueur maneuver. That's going to be an unusual case. But usually, if you're doing 2 simultaneous free flaps, you're sort of putting them remote from one another. And in those cases, I will try to dole out some ratio of superficial to deep veins. One has to wonder if you took 2 deep radial veins at the wrist level, could you interrupt the deep radial veins at the proximal forearm level and use those 2 and everything would be fine in the end? And I bet the answer would be yes, but I don't have any particular answer for that. What do you think about that, Babak?
Yeah, I mean, I think, I haven't done too many endosides on veins that distal. Definitely more proximal. I've done plenty of endoside veins, and also in the lower extremity. We've gone to femoral vein endoside, kind of in the mid to proximal thigh and that kind of stuff. But in the kind of the mid forearm to distal, I think I agree. I basically go to the cephalic, and there's usually enough side branches that I can use, and there's the VNA typically are good enough that you can use that. So it tends not to be as kind of clinically as much of a need as you might think it is. There are many fewer arteries to use for inflow than veins for outflow fortunately, in the upper extremity.
Yeah, because you're generally doing the veins end to end, you can go remote and cut them and transpose them from pretty remote areas and bring them into your zip code if you need to. One of my favorite moves in that regard is in replantation. If you feel like you can't reach your replanted part, just sort of, let's say it was on the index finger, you could sort of meander out on this completely uninjured ring finger or a middle finger, harvest a long dorsal vein, and then transpose that onto your injured finger, which is a nice way of getting length. I mean, of course, usually what we're missing is the vein in the part.
Right.
Not much veins in the hand, but it's one way to do it.
Yeah. Looks like someone is asking an MFC question, so not really related to this talk, but they're saying if you've ever used MFC for trophic ulcers on the foot. Any thoughts on that?
Specify a little bit on that. Now, are you talking about using the MFC to perform osteotomies, to unload weight-bearing areas in the metatarsals, or tell me give me an example of how that's Lena.
Yeah, and maybe while Lena is either typing or turning their mic on, we can talk about the take back for replants, the next question, while we're waiting for the clarification. This is always the question, is this a no take back replant? And if so, why? And what replants do you take back for a venous problem?
Do you try and estimate DIP joint levels if vein fails? So I'm a pretty minimal replant take backer. We've got a more aggressive replanters in my center, particularly Ryan Katz. He'll take stuff back more, but if my veins are going down, I'm going to leeches, and I'm going to try and carry the day. I know it's old school, and I would never accuse myself of being one of the best replant surgeons around, but I usually go to the wall the first night, and if it's a child, if it's multiples, and it's clearly arterial, those would be indications for takebacks. But this sort of slow venous loss, I think I'm too much of a loser to make that work.
Well, I definitely would not say that about you. But I think I would agree that I think in our experience, if we do take a replant back, it's usually for an arterial issue, unless it's a venous problem or proximal. So let's say you had a hand replant, it's congested and that kind of stuff, obviously a very different story. And so I will agree with you there. And as far as at the DIP joint level, yeah, I mean, there are plenty of veins you can do at the DIP level. But if they go down, then I usually just go to leaching or even doing heparin scrubs and feeding it. So I would agree with you on that one. And looks like there's a follow-up clarification by Lena on the maximum size of corticoperiosteal graft that you can take from the MFC. That may not be a clarification, maybe a new question. Oh, actually, there we go. Correct for unloading pressure-bearing areas and for covering the ulcer.
The only time I've really done MFCs for lower extremity for anything in the shoe in that area would be for taluses, or I did one for a calcaneus for an osteotomy, and that was as directed by the foot and ankle surgeon who was doing this corrective osteotomy to open up and obtain more height of the calcaneus. So I suppose that's an N of 1. I've done a couple for MTP joint fusions that had failed multiply, one of which was after a failed osteotomy for what do you call it? Not hammer toe, but when your MTP joint is medially deviated, it's called.
Oh, I'm blanking.
Yes. Anyway, bunions. Yeah, for bunions.
Yes.
That's a word that so infrequently crosses my lips. I can't seem to hold on to it. So yeah, for bunion surgery, so failed bunion that ended up in, these cases happen in the foot and ankle world where seemingly innocuous elective operation goes sideways, and then the next thing you know, you've got an MTP with bone loss and non-union. So those cases we've MFC'd. That's the grand total. I've never done it for a midshaft metatarsal, nor have I done it for a total ankle fusion. So I think that's probably the only time I've done it for really unloading because of issues of weight bearing on the plantar surfaces for that calcaneus case. I don't have any particular tips on that though. I don't think I've got enough experience to speak to it. There was a question about the size of cortical-periosteal graft you can take. From a perfusion standpoint, it perfuses the distal 13.7 centimeters in the medial aspect of the femur using the descending interchancular artery, but you would never harvest that much because of concerns of fracturing. So these days, what we do is limit our cortical-periosteal harvest to 7 centimeters, and if that's a lot, and if you're harvesting 7 centimeters, we take it very thinly, like truly cortical-periosteal, and if we need a bunch of bone graft, like cancellous, we'll get that from the tibia. I say that only because we have had one fracture, and we did publish that, and it was a disaster case where, in the end of the day, the flap itself wasn't so big, but I think in retrospect, what I criticized myself for doing is just going hog wild in the depth of my cancellous harvest. And I undermined the support of that condyle, and I got a unicondylar fracture, which was a horrible experience. But so I and we as plastic surgeons have always focused on what's the maximum width and maximum length. And I think really it's the depth is important as well. So sort of answered your question.
Well, Jim, I think in the interest of time, I know it's pretty late for you, so I don't want to keep you up too much longer for this.
No problem.
Maybe we'll just wrap it up after Gopi's question. Any thoughts on the dominance of Allen change after end-to-side anastomosis, if you think that changes over time?
So that's interesting. So the question would be, first of all, I think if someone's Allen's test is abnormal, I don't think it's going to become normal. If it's normal, it certainly can become abnormal. But now, after we do an end-to-side, will we make a normal Allen's test abnormal? I think that's the heart of the question. And I don't know, I've never experienced that, but I do know, at least from the data that I showed you, that the flow velocity downstream does not change, nor is it less than the other vessel on the same limb that we called in that study the collateral vessel same limb. So if you do an end-to-side anastomosis into radial artery midshaft form, the flow, antegrade flow in the radial artery distal anastomosis is at the same flow velocity as the ulnar artery in that same limb. So that data would seem to say no.
Great. Well, Jim, thanks again. This was truly an awesome and amazing talk, and I think it's different than most talks because it's not just showing cases, but it's talking about things that you have discovered or learned over many years of doing very complex reconstruction. And I think these types of talks, I think you can learn a lot more from personally than basically just seeing data on various things. And I think that's definitely one of the things that I enjoyed the most about this talk. And thank you so much for making yourself available for that.
Well, thank you, Babak, and thanks to all of you. I know we've all been on Zoom things like crazy, and it's very difficult to finish talks because there's no sort of audible feedback. But I really appreciate it. It's been great to connect with you guys again, and I'm happy to do it at any time in the future.
Great, thank you so much. And we may very well take you up on that offer.
Thanks a lot, Jim. Anytime. Thanks, guys.
And then just a quick housekeeping point here for those on the call. So if you go to our educational website, microsurgeon.org, and you'll see that there's a section called lectures. And if you go to that, you actually will see all the videos that we've put up, and this will obviously be included as well. And you'll see an upcoming schedule on the right, as well as a Google Calendar that you can import into your own Google Calendar. Tomorrow morning, we have Dr. Chris Peterson discussing what he's learned in 40 years of microsurgery. So it should be a fascinating talk. So looking forward to seeing you all then. Thanks again, Jim. I really appreciate it.
Thank you. Have a good night, everybody.
Take care. Bye-bye.
Bye.